So the first question is addressed to you all, and I really like it. It states, in our school, we teach our children about the biological aspects that lead to getting babies, giving birth, but we do not educate them about the importance of breastfeeding. Why? Or better said, why not? Would you like to answer, Rebecca?
Sure. No, I think it's a really important question, and there are, at least in Canada and the US, multiple, both states and cities that are working hard to implement this to be part of the mandated curriculum, because if it will help people understand the importance of lactation and breastfeeding, but also to normalize lactation and the breast, and just to have it be more acceptable in society. I think the earlier we start, the better. My kids definitely, as they talk to their friends, none of their baby dolls have bottles. They breastfeed their baby dolls, but we need to start it early. It needs to be in elementary school, I think.
And what is your perspective, Sarah, from UK? Do you have similar models so that it's already taught at school or during kindergarten?
No, it's not, and I think most of our dollies still have bottles. And I would love to learn from our North American counterparts.
And Diane, what about USA?
I actually think this is such a great question because at University of Pennsylvania, my nursing students in my whole semester course have worked extensively with high schools and even junior high and even as early as daycare to provide education. And in Philadelphia, which I told you earlier was the city of motherly love, we actually have very strong lactation policy in our schools that protects the rights of pumping parents and education provided. So there are models out there, they're just not consistently being applied. But 100%, it should just be part of our education system because, that's what breasts are for.
Good point. The next question is also raised by Professor Modi. What examples of good practice can you give us that educate men or partners about the benefits of breastfeeding? Who wants to take that question?
I can start.
Yeah, good.
Because when we do our prenatal intervention, we actually ask for the whole family to come. So, dad, if it's a same-sex couple, other mother, grandparents, we don't limit who can come. I think it's really critical to have that partner buy-in. If we are talking about a heterosexual couple, data from the US clearly shows how important the role of the father is. And I could give you so many instances that as soon as fathers learn the science, they are absolutely sign me up and I will do whatever it takes to support my partner in their lactation journey.
Do you give advice to the fathers or the partners in your unit?
Yes, definitely. And I think the key there is around both parents being complete partners in care. And I think one of my most frequently used phrases when I meet the parents antenatally, and traditionally that used to be about talking about survival outcomes and percentages, is really about setting the tone for the whole neonatal journey, that the parents are never visitors. They are absolutely both crucial partners in care and partners in the importance in breastfeeding as well.
Yeah, I think you agree, Rebecca, right? How do you handle it in your unit?
I think it's involving the whole family. I think especially in Toronto is one of the most diverse cities in the world. The majority of our population is foreign-born, and so the majority of our babies are delivered to recently immigrated families. And we have found in our unit, it's the mother-in-law. She is in charge of everything. And so if you don't have mother-in-laws buy-in, it's not going to happen. So it's the whole family getting them involved.
Yeah, so there's common ground that you need to get the buy-in from the whole family, also the mother-in-law. The next question goes a little bit deeper into the composition of antenatal expressed colostrum. It states, do you know whether the composition of antenatal expressed colostrum is the same as colostrum after birth? Would you like to state on this?
Well, it's not part of our research study, but I mean, if you think about the secretion of the colostrum, right, when we're pregnant, we can't have copious amounts of it being produced because of the hormones of lactation. But when people give birth, the colostrum is there, and then what drives its ability to go up is exactly what Rebecca went over on her talk. So we also have data from my colleague in Poland about tandem breastfeeding and that the milk changes and the nutritional value has been studied. So I think we can feel confident about the value of the colostrum.
Can I come in there?
Yeah, sure.
I also think that certainly for the preterm and then the preterm infant and the pump-dependent mum, it isn't necessarily about the nutritional content. It's about the messaging of the importance of that early colostrum and the importance of early expressing, and just that emphasis that it, so many mums think they need to wait until their baby needs milk. So for me, it's more the act of doing it than necessarily the content. It's about that messaging's really important early on.
Yeah, colostrum is not food.
Right.
It's medicine.
It's medicine, right? Right. And I think that's important too. It's like getting people to think differently. It's like, it's the bioactive nature of human milk that is what makes it so spectacular and so magical, like Rebecca talked about.
Exactly. I also know a neonatologist who said colostrum is for the gut. That's what surfactant is for the lung, and that's absolutely true. But sometimes... Okay, good.
So we talked to our families how colostrum is actually really similar biologically to amniotic fluid, which is a super cool concept, and that it's just part of this continuum from pregnancy to post-delivery. And so it's the same kind of growth factors and immunoglobulins and immune factors that they're swallowing in utero that then colostrum continues. So.
I think you're perfect in storytelling, Rebecca, and I know your parents would love it. But sometimes we have lack of stuff and busy schedules. So how can you support mothers to take informed decision in times where there's a lack of stuff? The $1 million question.
And I think,
I think this is where it goes back to it has to start before they give birth, right? I hear all the time from obstetrician providers, midwives, or OBs, I don't have time to talk about that. There's no time in my schedule. They have to go take a separate class. You can say 1 minute. You're listening to fetal heart tones. Do you know how cool it is that your breasts are making milk? Do you know that there are, it doesn't take much time, but we have to start that messaging before they give birth. Because if they know the science and they know the physiology of lactation, then they can control their own journey. Yes, they need support from hospital staff. Yes, they should have support. But if they know that science and that physiology before they ever give birth, then they can direct their care. And I think they can also push the neonatologist or the NICU or the labor and delivery staff, to demand, that pump, to demand that help, to demand doing oral care, to demand skin to skin.
Yeah, it can be very empowering for these parents, to stress that. Do you want to comment on that?
I absolutely sympathise with this problem. I imagine it's been similar across other countries, but during the pandemic, the UK's staffing situation across our whole perinatal services, very, very challenging. I think that one of the solutions is this needs to start becoming everybody's problem. This is everyone's responsibility. I would love to see during obstetric training that we're training the obstetricians in the importance of breast milk and how to have those conversations, the few useful phrases that they can do easily, that they don't have to do a 2-hour class or seminar on it. And I'd love to see them talking to women in preterm birth clinic and all of the different opportunities to get the high-risk women, the women who are going to develop preeclampsia, gestational diabetes, all of the women.
And that's especially a topic that gynecologists like a lot. So when you talk about obesity, diabetes, gestational diabetes, they are very much interested. And then when you talk about lactation, hey, yeah. The next question is a little bit provocative. Should we make formula milk more expensive to demonstrate or demotivate parents, mothers, to go for the easy choice? Or give formula only by doctor's prescription? It was voted.
That is provocative.
So I think for me, the issue with this is that we do have some parents who can't make milk or won't be able to make enough milk. And so if we ever got to the point that you could go to the grocery store and pick up pasteurized donor human milk, right, in the grocery store to feed to your baby, that would be different. But like, we do have people who won't have the ability to make enough milk, as I talked about in my talk. So I think that makes it difficult. But I also will say, formula is very expensive. And I don't think many times people do the math for families, because they're like just buying one bottle at a time or one tin at a time. And, you know, if you actually do the cost calculation, that cost of formula is way more expensive than purchasing a breast pump or getting the things you need to be able to provide milk for your baby. But I think we have to change our language when we work with families.
Yeah, no, I agree. I think again, since families are just purchasing one can at a time, like they see the cost of a private lactation consultant or the cost of a breast pump as this, you know, fixed one-time cost, which can be a lot for families. And so we also then need to find easier ways for families to access those services. Like at our hospital, if the mom can't afford even a personal grade pump, they can get it on a payment plan. So it's $20, $25 a month. So then they don't have that upfront big cost. So then that's not a barrier.
But that is an initiative that is driven by you, right? Because you are passionate about breast milk and breastfeeding, but we see a lot of hospitals where this is not the case, yeah? And in this case, yeah, there should be a solution at hand by the government also and funding sources, right? Mm-hmm. So in Germany, we have a very nice system. We have 1 year maternity leave, and then you get the pump on prescription when you have issues or risk factors for 1 month, cost free of charge. And that's nice, but it's not the same in all the countries. That what I had to realize when I joined the European team. And this is something that is really essential for the parents, yes, to get access to the pump equipment. So the next question goes into the risk factors, and especially women with cesarean birth. So sometimes when there's a cesarean birth, it is the pain felt by the mother that delays and complicates the first collection. So how do you start breast pump session so early? I think that was for you, Diane.
Sure. So I actually like to refer to the group I worked with in Japan when they implemented my model. They actually put the hands-free bra on the mothers before they gave birth, and they had everything hooked up. And you know, the Japanese nurses, they were very, very precise, and they measured everything, and they were very just, you know, determined that they were going to get everyone expressing. And so that is one way that they handled it. But for us, when we looked at our cesarean birth moms and the people who were the late initiators, which were only 10%, it was usually because of pain or vomiting. And so that then allowed us to also go back and look at provider, because we actually found that there was a certain anesthesia person who the parents seemed to have more problems after birth. And so we but we looked at it on a per person basis. And so I think, you know, knowing that as soon as possible after birth, it doesn't have to be that first hour, but in that first 6-hour window, and then thinking about the other people who can manage that experience. For us at Children's Hospital of Philadelphia, it's the support person. Mm-hmm. So it's not the mother who's sitting there going like this. It's actually the father, grandfather, grandparent, it's someone else who's actually helping the person with expression. Or it can be our NICU nurse who comes for the transport of the baby too.
I think this is also the case in your unit, Rebecca, right? You have also
at our perinatal centers across the street. Yeah, it's the same thing. You need to have someone who's dedicated to that job. You cannot expect a mom who has just had surgery to like be basically doing anything. So it needs to be their job, but they also have to be like, there has to be like feedback or follow up to make sure that that job is actually happening.
Yeah.
But I think the pain element can also be a perception too, sometimes by the healthcare provider, like, oh, we don't want to bother the mom. But if you actually ask the mom, like she wants to provide milk.
And there is actually some data published about that cesarean birth moms have better pain control. Like, so it wasn't specifically on mothers who had preterm babies, but it makes sense because if you're
We've had enough
oxytocin,
epidural.
right?
Yeah.
Well, you had some medicine, right? Epidural, and then you have beautiful oxytocin and prolactin circulating. So they actually had a better or less response to pain. They felt better.
Yeah. Would you like to comment on that too, or totally agree, Sarah?
Totally agree.
All said. That's good. So the next question goes to you, Rebecca. Does hand expression of mother milk really not stimulate prolactin response?
So there's a very small there's not no prolactin response, but it's very small, and so definitely not enough to really have that stimulation of feedback. And again, those first couple weeks, that prolactin surge is really, really critical, and so if you will miss that window of opportunity. So,
Yeah.
and I think I do hear people argue that it's hard to get the colostrum out with the pump, or you're worried you will lose colostrum, and so that's very reasonable. Then hand express, get that colostrum out, and then pump, because again, it's not about getting the milk out; it's about the stimulation. So.
When do you advise to pump, Sarah, in your unit or BEPAM? I know it's quite early, or earlier than the 6 hours we mentioned, right?
Yeah, so I think we're aiming for expressing or either by hand or by pump, but definitely recommending pump, but recognizing that there are still a lot of change that needs to happen for everyone to get on board with that plan. Within 2 hours of birth, we do talk about antenatal expressing. In the preterm setting, that can only really be done when birth is absolutely inevitable. So the classical example of a woman whose preeclampsia is worsening, they're planning to take her to theatre for cesarean, takes about half an hour to get her ready, let's express then. There's this obviously theoretical risk that nipple stimulation may induce delivery earlier. I think if you've met women who've breastfed successfully all the way through a second pregnancy, they would say that's clearly rubbish. But that barrier is really blocking the the antenatal expressing for a lot of women.
The next question goes to Rebecca and addresses the biomarkers. What is your opinion? Should every NICU mother have sodium assessments?
I'm not sure, but I think we're hoping in the next year or two with our data, and there's also I think a lot more people getting excited about it. I think it would be great to have this objective measure, again, to do personalized prescriptions and to also, reassure moms if they don't think they're making enough milk, or even conversely, we've talked about situations where, where moms have lots of risk factors and they are like pumping their poor hearts out, and it's just not going to happen that they're going to make an exclusive supply. And so we can say, well, today let's pump 2 more times. And you know what? If your sodium doesn't change, it's not worth it to do that extra pumping. It's worth it to rest. And it's okay. Like every drop counts. You're doing everything you can. And so we could, I think, use it in a myriad of ways.
I'm curious, how do you measure it? Is it already a bedside method, or do you take the mother milk to the lab and then do all the assessments?
So initially it was taken to the lab, but now there are basically just off-the-shelf sodium meters that you could use to measure sodium in sparkling water or in breast milk or in pond water or whatever you want to do. It's not made for breast milk, but it's been validated by Dr. Getty's lab to be comparable to lab analyses.
And you literally only need
It's
a
just
drop.
a drop.
It's a drop.
It looks kind of like a COVID test,
Yeah.
or like a pregnancy test.
Cool. What about domperidone? What's your recommendation for this if pumping does not increase the amount of milk? Do you want to take that question, or?
I mean, we use a lot of domperidone in Canada. It's not approved in the U.S., but sometimes I think moms get it from Canada. My concern with domperidone is that it is like the go-to panacea for lactation problems. And we'll have moms who, will ask the LCs about domperidone, when they're, day 4 postpartum, which is ridiculous. Or they'll be asking at a couple weeks, and you actually delve into it, and they're pumping 4 times a day. And like no amount of domperidone or any drug for that matter will actually replace effective lactation practices. And so I think that is the problem, that it's used as this Band-Aid or this therapy, when really a lot of the time we probably could just optimize lactation support and be as or more effective. I think it probably has its place when you have done all those things, but not before.
Mm-hmm. And you don't use it so often.
Well, we
USA.
can't anymore. We used it prior to the FDA banning it and putting a black box warning on it. But I will say we used it in those situations where the parent did everything they could and still didn't come to volume. And in those cases, it does work. I mean, it is very effective. What I worry about the most, Rebecca, or the people buying it from Canada, is the people who don't tell their healthcare provider and don't have an EKG done to make sure they don't have a long QT interval. And parents are doing it and they're not informing their provider, and then we could put someone at risk. So that makes me nervous. I've been talking to the FDA in the US for decades.
Yeah, would be really similar. So do use it, but have made a really clear recommendation that it is no substitute for all of the other steps that need to be taken. And actually, when you do take those steps, there's a real minority of women who need it, but then it does appear to be helpful. But then we're lucky that women can't buy it, and they have to get it from a healthcare provider, which means you've got that safety net around the woman, and we've got really set, structured advice we use for healthcare providers when considering prescription of it.
The next question, again, addresses the effectiveness of pumping. It states, is there a big difference in the use of electric pumps versus mechanical pumps? I think they mean hand pumps.
I mean, there has been studies on this. There have been RCTs, actually an old one by Paula Meyer, I know, specifically looking at electric pumps versus manual pumps, and the electric pumps are more effective. You do get more milk in the first week, as well as later on. That being said, if you literally do not have any access to an electric pump, it is far superior to hand expression, because a manual pump still has suction.
Yep.
So.
And I think that I can speak to it from the perspective of my work in Thailand, India, and Botswana, where it is harder to get access to, a hospital-grade computer chip pump. In Thailand, at the Children's Hospital, they set up a dining room table, and they mounted Symphony pumps on it, and the moms all sat around the table and pumped together. They didn't pump the whole time with the Symphony pump, but they had it during the critical window, right? They were able to use it right after birth. And in my work in Botswana, the same thing. It was like using it during that critical window to get the effective stimulation, because it's also, once you bring someone to volume, it's a lot easier to sustain that with a hand pump or even hand expression if we can get their volume up high.
That prolactin surge isn't as important later.
So yes, 100%.
Great. In which women should you express milk before birth, also during pregnancy? Is there not a risk to stimulate childbirth? That's the question.
I think that probably comes to my point that I made earlier. There is this theoretical risk. I'm not convinced by any evidence that it's really high risk, but we ended up making the recommendation that when birth was inevitable for women who were going to give birth preterm, but equally I think then in the nearer term, women with gestational diabetes, I'm a big fan of that practice.
Yes, and we also have very good data about that. So there's this Australian study called DAME, and they included more than 700 women and expressed milk before birth, and there was no higher risk of the infants going to the neonatal intensive care unit or any risk of induction of labor, but they had no risk factors.
It was a very healthy population.
But I also think it's really important to remember that nipple stimulation is different than antenatal milk expression. When people are doing nipple stimulation for labor, they're rolling and twirling their nipples. When you do AME, it is like doing hand expression after birth. And so they're two totally different concepts of how you're doing a nipple stimulation versus antenatal milk expression. And we lay that out in the one article by my doctoral student and I. I do worry, though, that at this point of time, we don't have a lot of objective data. Even though the DAME study was a large RCT, they really did not do a lot of objective measurement of milk. And so that makes me nervous because, at least in the US, people are seeing TikTok about antenatal milk expression, and they're like, oh, I should do that because I saw it on TikTok. And I don't think we have the data yet to routinely recommend and support it.
It's a very small volume, so we don't, like, I agree, I think I remain to be convinced that it's actually going to modify outcomes. So.
And I will add, I was in Australia in March speaking for the Perinatal Society of New Zealand and Australia, and one of the members of the DAME group actually got up and did a presentation and said we shouldn't recommend this practice. And the reason she said that was because they did qualitative interviews with women, and the women said it was too hard to do, or they didn't get any milk or anything like that. But I went up to talk to her afterwards because I said, well, how much support were the women given after they were taught it? And they weren't. And so, if you're going to teach this practice, you have to give people appropriate expectations of what they would see in terms of milk, that they might get, and that experience. And so, in our study at CHOP, my PhD student talks to the parent every other day, to give appropriate guidance. So I worry a lot that people are doing it with not enough evidence yet.
Yeah.
Thank you very much for this reply. The next question again comes from Professor Modi, and I think it's a really interesting one. Do you have any examples of reconceptualizing the image of the breast from a sexual to a health perspective?
That's a tough one. I think it's just I think it's just from a societal level, we just need to normalize things. So the more women we have breastfeeding in public, the more it's normalized in our NICU with moms. If they want to breastfeed without a screen, it's not their problem. If someone's uncomfortable, the problem is with them and they can leave the room. It's not mom's problem. It's not mom's responsibility to cover up. And the more that we can, again, show that it's not sexual, that is literally why we have breasts, is to make milk. And that's obviously a long-standing historical precedent of sexualization of the breast that we're not going to quickly modify, but we just need to see more of them everywhere.
And breasts are not also sexual in every country. So there are many countries where the breasts are just out and no one's batting an eye. So, we have to think that in some countries the breast is very sexual, but not in all. But I do think normalizing this as part of the anatomy and physiology of, this is what happens in the life cycle. This is part of the life cycle that we would expect to see.
It's how babies are supposed to feed.
Yeah. And this also tackles, again, the society level and our mindset here and our culture. And it should really be the most normal thing in the world, right? Because it's natural.
And we had in our institution, we have, again, since we have a very large immigrant population, we do have a lot of quite conservative patients, and there's been some pushback with our pictures of babies breastfeeding, and we have not backed down. That again, it's not if you don't want to look at it, don't look at it. But it's not the mom's problem.
So I have one last question for you. So you've all done a great job in similar areas, and I guess you're meeting for the first time in this constellation, right? Yeah. So we have always asked our audience, what have you learned from our speakers? But now I would like to ask you, have you learned something from each other today? Or what are your key takeaways? So Sarah, you just gave me the perfect hint. What will you write down? What will you change? Or is there any takeaway you would like to share with us?
I think I have held back from pushing the double pumping, not hand expressing agenda. I think I've just held back. I haven't wanted to rock the apple cart, and I think I will just get back. And I've just written how many more breast pumps I'm going to find charity funding for, and just really do a load of work and education with my team to dispel that myth. Because literally this week, I tried to get a breast pump for a mum who had given birth 24 hours before, and I was told, whoa, hang on, it's not day 3. So that is my take home.
Thanks for sharing.
Thank you.
I think I always learn I'm surrounded by like-minded people, which is always, it's just really exciting to be with people who are excited and who you know are going to go back and kind of bring some of these little tidbits to the bedside. And if we can get just even a few more moms breastfeeding, then the purpose of this conference has been served. I really liked your QI story, and I'm very inspired by your son. I definitely could not climb those mountains, and I hope that my 9-year-old does not ask me to do that. But I loved your story and surrounding yourself with positive people and smiling. That's great.
Any takeaways you would like to share with us, Diane?
So one of the things I really like is that, we're all representing different disciplines, basic science, neonatology, nursing, midwifery, right? And it's like, it has to be all of us.
Yeah.
And I think in my years of doing this work, I often see people, placing the blame game. It's the OB's fault, they didn't teach the mom. It's the neonatologist's fault, they don't support the mom. It's the nurse's fault because the nurse isn't helping them. It's, and it's like, no, we all have to.
Everyone's job.
It's everyone's job to support these families, and we need to do it in a positive and caring manner. Positive and caring manner. And you need those champions. You need the cheerleaders. It's hard work. It's hard work.
Thank you very much for your contribution, and I very much agree that the whole perinatal team is responsible. It's a task, right? And I am very much say a great thank you to our dear speakers. Big applause, please.